In this short video, I'm going to share with you some of the difficult cases of the pediatric cataract management. These are the key issues once we talk about the management of pediatric cataract. And one of the most important thing in pediatric cataract management is the management of anterior capsule and posterior capsule and the vitreous management, because it's very important to provide them the long-term clear visual axis. And the second important thing is the lens power calculation. As we all know that because of the children, the refractive status of eyes keep changing, and sometimes we come across the unilateral cataract in very small child, for example, less than 1 year. So in these cases, it's very important to do very thorough examination under anesthesia. Whenever any child comes to you, before deciding the treatment plan, always perform a thorough EUA or examination under anesthesia, because this EUA, you can examine the corneal diameter, you can calculate the lens power, you can do the biometry, you can see the optic nerve, you can record the intraocular pressure. One of the most important challenges in these children is taking precise key reading and the lens power, visual length measurement. And to do that, we can use handheld keratometer, we can use the A-scan, biometry, and then comes to surgical technique. The surgical technique in these small kids, the most important point is the capsule management, because these capsules are elastic capsule, and there are various techniques are described to do the capsular axis. In this video, I'm going to share with you one of the techniques described by the Steve Arsenault, what is known as ultimate soft cell technique. So in this technique, you use the supercohesive viscoelastic such as 0.5, then you get a small pocket of basis, and then you use the trapping to guide in that pocket. So with this technique, you can do the precise capsular axis, because these capsules are very elastic, and in children less than 1 year of age, the sclera is very, the low scleral rigidity, there is molecule test pressure, and the capsule is very elastic. So therefore, it's very difficult to achieve the precise capsular axis. So once you use a supercohesive viscoelastic such as 0.5 or 0 GD, then you can do precise capsular axis. The irrigation aspiration is very easy and straightforward. I'm doing it in bilingual irrigation aspiration. There is a not universal consensus to implant the intraocular lens in less than 1 year of child, but in this case I did implantation of the lens because this was a unilateral visually significant cataract. In my practice, I use single piece hydrophobic intraocular lens because of better biocomfortability and the better design of the lens intraocular lenses. And in order to achieve the long-term visual axis, it's very important to do the primary posterior capsulotomy and anterior vitrectomy. I use vitreous cutter to achieve both things. Using the vitreous cutter, I perform the primary posterior capsulotomy and anterior vitrectomy. And it's very important to suture the main incision and side port incision because of the low scleral rigidity causing this mouth effect in these cases. And so therefore, always suture the main incision as well as side port incision, because children tend to rub their eyes. And I also we use the preservative-free intracannular triamcinolone injection to extend the vitreous. This by helping the preservative-free triamcinolone injection, we can see if there is any vitreous strain is there in the anti-chamber or not. And secondly, it provides very good anti-inflammatory effect post-operatively. So this is one of the case of pediatric cataract, and in our practice, usually we use intracannular moxifloxacin or Vigamox injection. And at the end of the surgery, I just once again double check, cross check if there any residual vitreous strain is there or not in the anti-chamber by just washing with the triamcinolone injection. And then once the chamber is sealed, then we normally do examination and anesthesia after 6 to 8 weeks, and during this period we can also do suture also. So this is the clear visual access in 8 weeks of surgery. This is another case. 2-year-old child with a dense anterior capsular plaque. Sometimes we see such situation where the very dense anterior subcapsular are very difficult to remove. So I try to like using, I'm trying to separate this plaque using the vitreous cutter or using, and also I try to use 26 mm sharp ready. And the plaque is very much adherent to the lens method, and with the gentle movement we try to separate this plaque, and once you remove this dense anterior subcapsular plaque, the lens method is soft, and you can use bimanual elevation aspiration to remove the lens method. And in children, as I mentioned before, up to 2 years of age, it's important to do primary capsulotomy with amblyopia. From 2 to 8 years of age, you can do only primary posterior capsulotomy, and after 8 years, you can leave the posterior capsule intact. So this technique is very important to maintain the clear visual axis and to achieve the long-term clear visual axis. So once again, I'm using the timesynode acetonide, and this is another case, another infant. This case is 1-year-old, and here I'm showing you the posterior capsular plaque healing. So once we remove the lens method, this is the posterior capsular plaque, very much adherent to the posterior capsule. So we use a straight 26 piece needle to peel this, to separate this plaque from the posterior capsule. And once you separate this plaque, then you can remove this plaque with the rubber exploration forceps. And once the plaque is removed, then you can implant the lens in the capsular bag. And once again, after implantation, primary posterior capsulotomy and anti-vitrectomy to achieve the long-term visual clear visual access. So in these cases, it's very important to do periodical examination under anesthesia, record IOP, do refraction, because amblyopia management is also very important in these kids. So, one of the recent advancements in the technologies is the Bilateral Cataract, and I'm just going to, this is my last video, use of Bilateral Cataract in a 5-month-old child, because we know that creating a capsular axis is very difficult in these cases, and because of elastic capsule, sometimes there is incidence of runaway axis, or sometimes the axis may not be the desired size. So, with the introduction of the nanopulse Bilateral system, this tool can be helpful to achieve the anterior capsular axis in infant and young children. So this is the handpiece of the Bilateral device, and you can see this is silicone ring with the magnol ring, and this can be restricted, and this can be inserted to 2.8 mm incision. Now they have also introduced a device which can be introduced through 2.2 mm incision. So once you position the device and you apply the suction, there is a creation of capsular axis by, and you can see this is very precise, and this is the capsular axis in a 9-month-old child. And once you achieve a good capsular axis, then you can remove the lens method with the bimanual elevation aspiration, and then after removal of the lens method, you can implant the lens, and you can do the posterior capsulotomy and the anterior vitrectomy to achieve the long-term clear visual axis. So this is the last case of the Bilateral Cataract in a young infant, and here we are doing the primary posterior capsulotomy and anterior vitrectomy, and once again the injection of radiologically transferred in the anterior chamber to stain the vitreous. And last but not least, it's very important to suture these cases, the side port and main incision, because the children tend to rub their eyes, and because of less scleral rigidity, there is fish mouth effect. So, in summary, it's very important these are some of the guidelines to manage the pediatric cataract, and the management of pediatric cataract remains a challenge because of the changing refractive status of the eye and frequent and long-term follow-up. They need lifelong follow-up, and amblyopia management and periodic examination of the eye under anesthesia to check up for glaucoma is very important in these cases. Thank you once again for your attention.